Good morning, everybody. This is Dr. Ashish Nabar from Mumbai, and I am the convener for this IHRS DNB Arrhythmia teaching program, which, as you can see, is in the fourth year of its running. Every Sunday, first month, usually around this time, we have the program where the faculty from all over India, not necessarily only academic institutes, but also from private institutes in the country, private practices in the country. Anybody who is a good teacher and who is interested, sometimes they volunteer, and at times I have requested them. But we really have no dearth of faculty coming on this program to teach the arrhythmia and heart failure nitty-gritties to the postgraduate students around the country. We have also been keen that some early career cardiologists who might want to eventually get into mainstream EP, they can also use this as a platform to get interested in the subject. And we have sent out invites to the neighboring countries also to the industry. This time, Dr. Shomu Bohra from the reputed UN Mehta Institute at Ahmedabad himself volunteered that he wanted to do it, and he always does a serious job out of it. So this time he is going to discuss various ventricular arrhythmias around the conduction system, and most of us to start with learn about conduction system in relation to bradyarrhythmias. So I'm sure this session would be of interest and would add to your understanding of how ventricular arrhythmias revolve around the conduction system. Without much ado, this is a very crisp program that he has construed with his colleagues in the institute. And I'll hand over to him to directly explain to us what his mind was thinking when he set up this program and introduce his faculty. So Shomu, without much ado, let's get on, and the stage is yours.
Yep. Thank you, Dr. Ashish, for giving us the opportunity. And it's always a pleasure to speak in IHRS forum, which has always been associated with academic excellence. First, I will introduce the faculty, Dr. Sameer Rane, who has been there with us since last 5-6 years, Dr. Raghav Bansal, now nearing 2 years, and Dr. Priyanka, who is there with us for the last 1 year. They're all as associate professors, and Dr. Priyanka is an assistant professor. And they are doing a very good job in handling the electrophysiology cases as well as the device cases. And we have a dedicated cath lab for EP, which is very rare to find in government institute. It's a very high volume center, and obviously we have a good DNB DM training program. What we learned over a period of years is what we want to share with the DNB students, and we have around 18 DM candidates every year. And what we see them is they primarily focus on bradycardia related to conduction system, as you said. And the importance of having fascicular VT, bundle branch reentrant VT, post-MI, Purkinje fiber VT is generally unknown to them. So what we thought is to introduce them to these basic concepts, and maybe some patients which they see in their clinical practice, they might find this. And these are the arrhythmias which can be easily treated by ablation or by medications. So that is where the importance lies. And that's why we chose this topic. And it has not been covered for a long, long time. So I'll definitely look forward for this session, and hope that it's a useful session for the DNB candidates.
That's right, Shomo. Well said. Yeah, sure. I must introduce also our moderators, both senior faculty from the IHRS. Dr. Haigreev Rao is from Hyderabad, and we have Dr. Bhim Shankar from Cochin. So I think they will provide good insights. I have kind of assigned them to a particular speaker to have a short, quick, and succinct discussion which covers what has not been discussed. But obviously, they both have the rights to enter anytime into the discussion and make some useful comments as we go through. Sure. So I think that's a great start, and we can have probably Samir starting, and Dr. Haigreev will moderate his presentation. Samir?
Yes. Is my screen visible?
Yes, very much. You can start.
Yes. Good morning, everyone, and thank you, Ashish sir and IHRS for this opportunity. I'm working as an associate professor at UN Mehta. Thank you, sir, Shomu sir, for the kind introduction. And today's topic for mine is anatomy and physiology relevant to conduction system pacing. So, although an anatomist named Purkinje had mentioned the conduction system of the heart as a part of its structural component, it was not until by Dr. Sunao Tawara in 1906 who originally described the conduction system and its postulated function. He drew a picture to describe a network of three distinct fascicles: the left anterior fascicle, the left posterior fascicle, and a left septal fascicle, which arise from the main left bundle branch before extending into a web-like meshwork of Purkinje fibers. This has become recognizable with the development of field of electrophysiology. Then in 1974, James et al. Described the right bundle as a cord-like structure. This figure shows an EP catheter entering the right atrium and placed across the tricuspid annulus to record the His signal. The approximate course of the right bundle is represented by circles, differing in their opacity based on its superficial or deeper course. The right bundle runs superficially in the upper third of the right ventricular endocardium up to the level of the medial papillary muscle of the tricuspid valve. And this superficial course makes it vulnerable for trauma even during catheter placement. After this, it courses deeper in the interventricular septum and again becomes superficial in its distal third to course within the ventricular trabeculations, usually traveling up to the right ventricular free wall along the moderator band. The left bundle is somewhat different. It is a broad sheet-like structure that emerges beneath the non-coronary cusp of the aortic valve and gives rise to a thin anterior fascicle, a slightly comparatively broader posterior fascicle, and in approximately 60% of individuals, a third fascicle termed as the left median or the left septal fascicle. The anterior fascicle crosses towards the left crosses the LVOT to the anterolateral wall and the region of the anterolateral papillary muscle. The posterior fascicle extends infero-posteriorly to insert near the base of the posterior papillary muscle and the free wall. The median fascicle runs in between. It runs in the interventricular septum. Then this knowledge is fundamental to understanding the pathways, surface electrocardiographic manifestations, and approach to ablation of ventricular arrhythmias that are related to the infra-ischian conduction system. Then Dumoulin in 1973 and Culbertus in 1975 revealed significant anatomic variations in the morphology of fascicular branches of the left bundle branch. They found four major patterns of left septal fascicle organization. The left septal fascicle can extend directly from the main left bundle branch between the left anterior fascicle and the left posterior fascicle. It can also be an extension directly from the anterior fascicle or from the posterior fascicle. And there is a fourth variation which is formed by contribution of fibers from both the left anterior fascicle and the left posterior fascicle. These contributions either form a septal branch or a septal fiber network. Then the relative refractoriness of the right and left bundle branches are rate dependent and discordant. At longer cycle lengths, the relative refractoriness of the right bundle branch is greater than that of the left bundle branch. And at shorter cycle lengths, relative refractoriness of the left bundle branch is greater than that of the right bundle branch. The relative refractive period curves a crossover can explain the presence of functional right bundle and left bundle in a same patient. The His Purkinje system are also subsidiary pacemakers, and they are under the control of the autonomic nervous system. The sympathetic nervous system enhances pacemaker activity through beta-1 adrenergic stimulation, and the parasympathetic nervous system inhibits pacemaker activity through muscarinic receptor stimulation. Then on the left hand of the screen is an area of any branching cardiac tissue, which provides separate paths for impulse propagation from proximal, which has been numbered as 1, to in the distal directions numbered as 2 and 4. If the tissues in these pathways are healthy, the impulse can conduct in a fast manner. And because of the long effective refractory period in cardiac impulses, the impulse would collide at site 4 and would eventually propagate only in the distal directions. This spot for collision can vary depending on the conduction velocities of the two cardiac conducting tissues. Then on the right is an area of depolarized myocardium at site 3 due to asymmetric severe local myocardial damage because of anything, fibrosis, ischemia. This imposes a conduction block from the anterograde direction. However, an impulse travels from site 4 in the retrograde direction towards 3 and very slowly into the damaged area. And if its propagation is slow enough to outlast the ERP, effective refractory period, of the tissue in front, the impulse can re-excite the proximal tissue. Then this impulse would propagate towards sites 1 and 2 and establishing a re-entry mechanism and cause arrhythmias. Procainamide, which increases conduction time within the His-Purkinje system, especially in a diseased His-Purkinje system, and also isoprenaline can facilitate induction of sustained bundle branch beats. And Strachey et al. Simulated different types of conduction disturbances. Right bundle branch block combined with left anterior and left posterior fascicular blocks. Additionally, right bundle branch was simulated in the presence of slow conduction velocity happening in the myocardium, LV myocardium, or the right ventricular myocardium, or the His-Purkinje system and whole His-Purkinje system. They have shown the ventricular activation in these different permutation and combinations. Then a unidirectional block and slow conduction would promote re-entry and can involve both the right and left bundle branches, or a single left fascicle, or both the fascicles. The right Purkinje network is, because it is not as diverse of the left bundle, has not been demonstrated to harbor intrafascicular re-entry. Then Bell Hassan and his colleagues had first demonstrated that these fascicular re-entries are typically slowed or terminated by verapamil. This verapamil sensitive slowly conducting tissue remains imprecise and has been an area of interest for the last many decades. And it may also be formed by a diseased Purkinje fibers, false tendons, or the ventricular myocardium itself. Then the widespread network of Purkinje fibers extend from the bundle branches towards the trabeculated myocardium and are well insulated from the underlying myocardium by connective sheaths. Thus, electrical activation cannot escape into the myocardium. Purkinje cells form electrical junctions with ventricular myocytes through Purkinje muscle junctions, and ventricular activation occurs at these specific sites. Then a transitional layer of cells serve as high resistance barrier between the myocardium and Purkinje cells, and they act as a gate mechanism. So if the impulse travels in an antigrade fashion from the bundle branch to the free muscle wall, it will propagate through tissues where action potentials will progressively lengthen proximal to the gate and progressively shorten distal to the gate. Then this gate is a property of the LV tissues, and it protects retrograde conduction from the ventricular myocardium up to the Purkinje fiber bundles. Pathologies such as heart failure, myocardial infarction lead to decreased cellular coupling and reduced conduction velocities, which disrupt this gate mechanism. This facilitates re-entry when the distal Purkinje or the myocardium is re-excitable and the proximal Purkinje in this area is still refractory. Then a study demonstrated that the origin of these Purkinje ectopy differ considerably between men and women, with RV origins predominating in men and LV origins predominating in women. Development genes could be involved in the arrhythmogenesis with sexual dimorphism in their expression. And this from the Zipes textbook of ET shows abnormalities of automaticity. Panel A shows a normal His-Purkinje action potential, and this automaticity in a His-Purkinje system can be enhanced or suppressed, and it can be achieved as shown in panel B by modulation of rate depolarization from baseline, by slowing of phase 4 depolarization, by increasing the threshold potential, or starting from a more negative resting membrane potential, all of which slow the discharge rate. The automaticity can also be increased by increasing the rate of phase 4 depolarization, thus yielding a faster discharge rate. Then panel C shows an abnormal automaticity with a change in action potential contour resembling a sinus nodal cell or a pacemaker cell when resting membrane potential is less negative. Then the Purkinje action potential has a faster upstroke compared to the ventricle action potential curve. It has a larger amplitude and a more pronounced early repolarization, that is phase 1. A more negative plateau potential and a much longer action potential and refractoriness than the ventricular myocyte action potential. The maximal action potential and refractoriness occurs approximately around 2 to 3 minutes before to their termination. As previously mentioned, the differences in action potential duration of Purkinje fibers acts as a gate to prevent retrograde conduction. Ionic currents and ion channel expression also differ between Purkinje cells and ventricular myocytes, most notably those associated with calcium handling. Then distinct pro-arrhythmic calcium-mediated mechanism can lead to ectopic after depolarization of the Purkinje cells. Purkinje cells are multicellular and they are capable of automaticity which generate escape rhythm. This pacemaker activity is observed as a slow diastolic depolarizations during phase 4 and is mediated by sodium-calcium channel exchange and a calcium-mediated chloride current. Digitalis is known to increase this form of automaticity. And quinidine is a class 1A sodium channel blocker that also reduces the inward and outward potassium currents, IKR and IKO, and to a lesser degree, inward calcium channel. This combined effect may make quinidine uniquely effective in controlling arrhythmias associated with action potential duration and phase 2 reentry, which has been postulated in idiopathic ventricular fibrillation. Then ITO channels are highly expressed in Purkinje fibers, possibly explaining the unique effect of quinidine. More about this channel in the subsequent talk. Then a gain of function of sodium channel is responsible for hyperexcitability of the broad His-Purkinje network. Thus, antiarrhythmic therapy with sodium channel blocker generally works. Reverse excitation contraction coupling occurs when changes in intracellular calcium alter changes in the membrane conductance. This leads to delayed after depolarizations and mostly this kind of arrhythmias or this kind of electrical activity seen in gene-based substrates as well as those and in acquired diseases also. Then Mohabir and his colleagues demonstrated that verapamil or nifedipine exacerbate depolarization and depression of conduction in Purkinje tissue which were exposed to ischemic conditions. They found that verapamil and nifedipine could suppress some of these, but not all potential mechanisms of arrhythmias which were induced during ischemia and by reperfusion. So to conclude, the Purkinje fibers are organized in an arborized, well-insulated structure spreading from the AV node, the bundle of His, and forming specialized ventricular conduction system for rapid and synchronous activation of the ventricles. Purkinje cells can be the source of arrhythmias and have been shown to trigger VF in humans. In the next sessions, we shall discuss the current knowledge of Purkinje-related arrhythmias. Then in the central illustration, Purkinje-related arrhythmias are shown. The fascicular VT was initially described by Dr. Zipes and colleagues in the 1980s. And in the last 2 decades, Dr. Nogami and his colleagues have given further insights into this classic arrhythmia. Considering the widespread meshwork and anatomic variations of bundle branches, the circuits of different tachycardias may not be constant between different individuals. However, their work by Nogami and his colleagues has added much clarity, and further investigations can help to further elucidate these complex networks. Thank you.
Yeah, that was a very good presentation, Dr. Samir. Now,
Thank you, sir.
before we go on to the subsequent presentations, I am going to just, because this was a important presentation, but for a general student of cardiology, so many things could be, academically intimidating too. So many terms. So I'd just like to provide some insights, a holistic insights to summarize what you already said, nothing new, but what you already said, and to emphasize the important points so that makes the subsequent speakers understanding very easy for the students. And because this is a topic which is actually the foundation for the next 3 topics that are going to follow. Now, what we have to understand is, as Dr. Ashish has very clearly said, the conduction system has been the focus for bradyarrhythmias and has been the focus for pacing and in general. But having said that, the arrhythmias in this area have been less understood and, more importantly, less recognized. That is the purpose of this session today. Because most of the times, ventricular tachycardias are related to structural heart disease or otherwise, but they involve the ventricular myocardium. Now, this is a completely different entity, and although this may look very less common, but the purpose of this whole session is that one must understand the presence, one must recognize that these can exist, and one must realize when to, identify these and treat them appropriately. Now, the first thing that appears is that the conduction system are fast-moving fibers. So the anterior and posterior fascicles and Purkinje fibers are very fast-moving fibers. Mechanism of arrhythmias, there are 2. One is the re-entry, one is the automaticity or the triggered activity. Now, for a re-entry, there is always 2 pathways are required, the slow and the fast. So generally in a patient with myocardial infarction, the slow is often given by a scarred myocardial tissue. And so one can understand why a re-entry occurs. The second thing is, when you have fast-moving fibers like the fascicles, now one of them could be diseased. Samir had said that in a passing mention that scarring, ischemia, or drugs, any of these can cause relative slowing of one of the conduction fibers. So that creates a relative refractoriness difference between one fascicle and the other, and one Purkinje fiber and the other. And then this leads to a substrate for re-entry. The other thing is, there is also a diseased areas of the Purkinje fibers, which are a very important point that have been studied by Hesseger, Belhassen, and subsequent researchers. Now, the importance of this diseased area is therapeutically important because this is verapamil sensitive. So when you have fascicular VTs and the other kind of conduction system VTs, where we give verapamil and it gets terminated, it is not that the conduction fibers are being affected by this. It is these diseased fibers which are, as Samir had mentioned, less understood. But then it is therapeutically very clear that these are the areas where verapamils give importance. Now, what is the importance of this fact is that not only for patients with fascicular VTs, interfascicular VTs, but in a small subset of myocardial infarction too, when you have a diseased Purkinje fibers causing substrate, the verapamil is useful for treating those VTs, a very small substrate. Because as you know, for myocardial infarction VTs, the drugs of choice are beta blockers and amiodarone in general. So we need to understand these particular small subset of VTs where verapamil is useful. This is because sometimes in storms, you are totally nonplussed what to do after using beta blockers and emetol. So that is one thing. So now coming to the, these are the important things about the fibers. The second thing is the triggered activity. Now, there are situations in the Purkinje where the mechanism of arrhythmias is not due to reentry, but due to triggered activity. So these triggers can occur either after a myocardial infarction, or they could also occur because of certain short coupled VPCs or idiopathic ventricular fibrillation. So these are the areas where the sodium channel restriction is important, where quinidine comes into play. So broadly, having summarized these things, you can classify these arrhythmias as, if you have an adenosine-sensitive arrhythmias, they are either a left, in order of prevalence, the left fascicular VTs are the adenosine-sensitive left fascicular VTs are the most common. These are either left anterior, left posterior fascicle, most common, left anterior fascicle, less common. The subsets of these are the papillary and the septal kind of VTs. Now, you can understand these are all reentries which I have spoken of. Then you have the interfascicular VTs and the bundle branch reentry, which is less common, but these are occurring between the fast conducting fibers, where between the anterior fascicle and posterior fascicle there is a reentry. When there is a reentry between left and right bundle branches, that is a bundle branch reentry. So in the common type of left anterior and left posterior fascicular VTs, the reentry is occurring between the fast conducting fascicles and the diseased Purkinje fiber, which is verapamil sensitive, the substrate. And the last one are the triggered activities, which can occur in a structurally normal heart, where you have a triggered Purkinje fibers generating VTs, or you could have a structurally normal heart, either a channelopathy or idiopathic. So in short, this is the basic summary of what we are going to see in the next, both in terms of therapy and physiology. Any questions are welcome.
So as of now, I think verapamil sensitive aspect you have covered in your presentation, which there's one question about that. I think we are good with this discussion. Only one thing about, if you want to comment on the inducibility of this conduction system related VTs from the atrial stimulation, either Haigreve or Samir can shed some light on that.
Go ahead, Samir.
Samir,
Yes, sir.
these conduction system related VTs, normally ventricular arrhythmias are easily induced by programmed ventricular stimulation rather than atrial stimulation, because
Yes,
there is a big delay in the conduction system. But these conduction system related VTs can probably be induced easily also by programmed atrial stimulation. Can you
yes, sir.
expand a bit
So
on that?
the difference in, basically, if there are two conducting tissues, the difference in the refractory periods between the two conduction tissues can cause re-entry. Basically, a block in one and a slowing conduction in the other can cause such a delay that the conducting tissue can impulse from the conducting tissue can proceed antigradely and retrogradely manage to enter the blocked tissue, and then similarly again re-enter the slowing conducting tissue and cause a re-entry. So a supraventricular impulse can cause a re-entry by this mechanism.
Sure. So that is in
That
relation
fine?
to the bundle branch reentry, and for
Yes, sir.
fascicular VTs, because they're in proximity of the conduction system, your atrial extra stimulus can easily reach
Can
into
also.
the substrate site and can induce. Yeah, sure. Haigreve, you wanted to say something?
Yeah. So this is a very important point Ashish has raised. So what happens is, in fact, when Zipes described the fascicular VTs, he made a very clear the important criteria to call it a fascicular VT. The first of them was the inducibility by atrial pacing. So the amongst others was verapamil sensitivity, the right bundle branch morphology, and absence of a structural heart disease. So these are the basic criteria to call it as a fascicular VT. So because the pathology or the pathogenesis involves the fast conducting fascicles, so these are one things where they are induced not only by the ventricular stimulation but also by the atrial pacing. Because when you start pacing from the atrium, you capture the His and the fascicles. and you are going to create a milieu for induction by creating a differential refractory periods which are passed through the atrial. So this is as good as pacing. So if you pace a fascicle near the fascicle or a few pace from the atrium, the ultimate result is same. You are going through the his and you are involving the fascicles and you are creating the milieu for the differential refractories. So you have to understand that these are the 4 important criteria to diagnose a fascicular VT.
Right. So I think the stage is well set for understanding the individual ventricular arrhythmias in relation to the conduction system. Great job, Samir. Let's move on to the presentation by Raghav, which is going to speak in more detail about what Hygrie was saying, fascicular VTs. Raghav, you can come on board.
Is my screen visible, sir?
Yes, very much. You can start.
Yeah, okay. So good morning, everybody. So straight down to my talk on fascicular VT. So what we understand of fascicular VTs, as we have already discussed, that there may be non-reentrant tachycardias, which are actually based on automaticity and triggered activity induced by exercise and catecholamines, and may be responsive to beta blockers and lignocaine and class 1A agents. And these may be associated with myocardial ischemia, and these will be discussed by Dr. Priyanka later. What we are going to discuss is about reentrant arrhythmias, which are verapamil sensitive. If they are dependent on fascicular reentry, and what we found on EP studies is Purkinje and diastolic potentials. What I'm going to discuss is about the classic idiopathic variety, which occurs in the structurally normal hearts. And there may be interfascicular reentry in diseased heart, which is a type of bundle branch reentry, will be discussed by Shomu sir. So to begin with the case vignette, this was an 11-year-old boy who presented to us with recurrent palpitations, had a structurally normal heart on echo. So this was the ECG during the palpitations. And so what we see on the ECG, it's a very narrowish looking QRS complex in the tachycardia. It's a regular tachycardia. And we have a right bundle branch morphology in the V1 with the initial peak smaller than the distal peak, which suggests that it's a typical RBBV morphology. And we have a deep S wave in V5, V6, and the axis is towards the left with 1 AVL and AVR being positive and 2, 3 AVF being negative. So this is a typical presentation of a fascicular VT. We have a RBBV, left axis deviation, and a narrowish looking QRS. So revisiting the history as mentioned by Hygrie sir. So in 1975, it was first described by Zeitz et al. In 3 patients by EP study, and what they showed that it was easily inducible by atrial pacing and not by RV pacing. It has a typical ECG pattern as discussed, and it occurs without structural heart disease. These 3 features came to known as Zeitz triad. Later in 1981, Belhassen described that there is a sensitivity to verapamil of this tachycardia, and this was the 4th specific feature of this tachycardia. Later in 1988, in the next decade, there was some progressions over this tachycardia, and it was discovered that this tachycardia may also occur with a right axis or an inferior axis deviation. And later in 1993, pre-systolic Purkinje potentials and the potentials of the conduction system showed that the conduction system is categorically involved in this tachycardia, and there is a role of radiofrequency ablation for the treatment of this tachycardia. And lastly, in 1998, there was another entity which was described, which was the upper septal VT. So 3 main forms of VT were described: the posterior fascicular, the anterior fascicular, and the upper septal VT. Coming to this main important clinical features of this tachycardia, so approximately 10% of the total ventricular arrhythmias are idiopathic VTs, which occur in the absence of structural heart disease. Fascicular VTs are around only 5 to 8% of these idiopathic VTs. 90% majority of these idiopathic VTs are outflow tract VTs. The usual age of presentation for these tachycardias is 15 to 40 years of age. In our country, we have seen that it may present slightly earlier, between 10 to 15 also commonly. There is a male preponderance with around 2/3 of the patients of the male sex. The tachycardia has typically a benign course. It is not associated with a sudden cardiac death, and there is no need of an ICD in these patients. And the usual presentation is with palpitations, dyspnea, dizziness, and they are mostly hemodynamically stable. It may be incessant, especially in children. And in these patients, it may be possible that these patients present with a tachycardiomyopathy, where it may seem that it is associated with this LV dysfunction. However, the typical ECG features and a young age may suggest towards a fascicular VT diagnosis, which is sensitive to a verapamil, and this tachycardiomyopathy may abate with the treatment of the fascicular VT. This is reported to occur in approximately 6% of the patients in the pediatric population with fascicular VT. Fascicular VTs may also spontaneously abate with time if they are left to in its own. And idiopathic fascicular VT occurs at this age only, 10 to 40 years of age. And when you see such an ECG morphology after 40 years of age, you should have a high index of suspicion of associated myocardial problem or other diseases of the heart, such as coronary artery disease or sarcoid or inflammatory cardiomyopathies. Important to remember is that approximately 10 to 25% of these fascicular VTs may be associated with AVNRTs and other supraventricular tachycardias. So you may have varied ECG presentation with a typical fascicular VT kind of an ECG and another ECG with a SVT kind of presentation. And even when you are taken to the EP lab with a typical fascicular VT morphology on the clinically, and you induce an AVNRT, you should not be done with it. You should try to induce a fascicular VT before getting out of the lab. So based on the ECG features we have discussed, the tachycardia may be from the posterior fascicle, which is the posterior fascicular VT, the QRS width 120 to 140, RBBP left axis. This is the most common type. Around 90% of the cases of fascicular VT are from the posterior fascicle. The less common type is the anterior fascicular VT, where the axis is towards right or inferior, and the prevalence is around 10%. The rare type is the upper septal, where the QRS is narrow and may have incomplete RBBB or a normal QRS morphology with a narrow QRS width and a normal axis. So initially it was described that the false tendons may be involved in the circuit, and the false tendon were first reported in 1989 with a case report where a false tendon was documented echocardiographically in a patient of fascicular VT. And the false tendon was surgically resected through a transapical route and cryoablation. And after the surgical resection, the tachycardia did not recur. And there was later such reports also, which were presented to suggest an association with the false tendon. However, in 1996, Lin et al. Found that there was a similar prevalence of false tendon between the posterior fascicular VTs and SVTs and other normal control patients. So it is unlikely that these false tendons are associated with the fascicular VTs per se. So coming to the mechanism and the circuit of this tachycardia. So the mechanism is re-entry, which is clearly demonstrated by multiple EP parameters, including induction and termination by extra stimuli, resetting with PVCs, and ability to entrain the tachycardia with ventricular pacing. There is a critical slow zone of conduction, which can be demonstrated on EP study. There is no automatic features like no warm-up, cool-down, or no reliance on exercise or isoproterenol to start the tachycardia. So this is a typical circuit which has been described for these kind of tachycardias. So I'll just get to my pointer. Yeah. So what has been suggested? These are all suggestions and hypotheses that there is a posterior fascicle, there is an anterior fascicle, and there is an abnormal Purkinje fiber in between. So this abnormal Purkinje fiber acts as a slow diastolic pathway, and it also generates some potentials which are recorded on the EP study. So these potentials which are recorded by these abnormal pathways are called the P1 potentials, and the potentials which are recorded by the posterior fascicle are called the P2 potentials. So in a typical reentrant circuit of the posterior fascicular VT, what happens? There is a re-entry where the impulse travels antegradally down this abnormal Purkinje fiber. There is a turnaround pathway at the exit side of the posterior fascicle, where it goes back into the posterior fascicle retrogradely, and then the re-entry ensues. Since the exit site is near the exit site of the posterior fascicle, there is an entry fascicular block, and we get a RBBB left axis kind of a picture. So this is a typical circuit, simplified. There is a slow pathway, abnormal slow pathway, which is verapamil sensitive, and there is a posterior fascicle, which is involved. So this is a typical circuit of posterior fascicular VT. In the circuit of the anterior fascicular VT, what has been proposed was that the anterior fascicle is involved as the retrograde pathway, while this same diastolic pathway remains the common factor. While in upper septal VT, what happens is that this abnormal diastolic pathway is activated in the retrograde direction rather than the antegrade direction in the previous two forms. And when it is getting activated in the retrograde direction, the anterior fascicle and the posterior fascicle are simultaneously activated in the antegrade directions. Thus, the exit is simultaneously at the anterior fascicular end and the posterior fascicular end, giving us a narrow QRS in the upper septal VT. So upper septal VT can be of two types, depending upon where it enters the anterior fascicle and posterior fascicle proximally. The distance of this point from the branch point of the His bundle. So if it is nearer to the His bundle branch point, the HV interval during the tachycardia will be longer. The QRS will be narrower. While if we are away from this branch point, our light bundle may be captured later, and giving a smaller HV interval and incomplete RBB kind of presentation on this upper septal VT. So the previous case which we had discussed in the initial period, So that case, we underwent an ablation for a fascicular VT. So he now presented with recurrent narrow complex tachycardias, and this was one of the pictures of the narrow complex tachycardias. So the child had a posterior fascicular block leading to a right axis after the ablation. And after the in this tachycardia, we gave him adenosine to document that there was VA dissociation. So first we thought that it might be an AVNRT, which may be associated with fascicular VT, but with adenosine, there was no termination of the tachycardia while there was VA dissociation, which was clearly seen, and it was diagnosed as an upper septal VT recurrence, and which was ablated later. So upper septal VTs are commonly seen after ablation of the posterior fascicular VT, and these are the late recurrence of new recurrence of tachycardias after the ablation of posterior fascicular VT. So this has been the common understanding of the fascicular VTs over from 1990s to up till 2015. And there has been some newer developments in the last decade, which I'm going to discuss now. One of the development is that it has been with the advent of intracardiac echocardiography, it has been noted that some of the tachycardias are actually reaching up to the base of the papillary muscle. These are not typically papillary muscle VT, that they are not automatic. They are reentrant only. These fibers are reaching the base of the papillary muscle, and they have a more apical exits. So now the Nogavi et al., what they did is they classified the posterior fascicular VT into the posterior septal fascicular VT and posteromedial papillary muscle fascicular VT. And similarly, the anterior fascicular VT as anterior septal fascicular VT and anterior papillary muscle fascicular VT. So this was based on the ECG parameters, where a more distal exit near the papillary muscle caused a deeper S wave and a more superior axis, in leading to a negative QRS in lead 1 in the posterior papillary muscle fascicular VT as compared to a posterior septal fascicular VT. Similarly, in the anterior septal fascicular VT versus the anterior papillary muscle fascicular VT, the anterior papillary muscle fascicular VT will give a deeper S wave in V5, V6 as compared to the septal fascicular VT, while the upper septal VT remains constant. So we have now 5 types of fascicular VT which have been described. However, there have been problems which have been reported with the current circuit, which may include that this abnormal Purkinje fiber potential, which is the P1, may not be always found in all the cases. And whenever it is found, it is not traversing the whole circuit in the diastole. The local ventricular myocardium may also be involved, which has been consistently showed with capturing of the ventricular myocardium and the circuit. The P2 potential, the posterior fascicular potential, may be dissociated from the circuit, which means that the proximal left posterior fascicle may not be a part of the circuit. And even after ablation of the posterior fascicle and causing a posterior fascicular block, it may not eliminate the posterior fascicular VT. So these points favor against the current understanding of the circuit, and it means that some other circuit has to be implicated. For this, Liu et al. In 2016 described these abnormal fibers may be smaller, may be perpendicular, which prohibits them to be recorded along the full length of the posterior fascicle or in the whole of the diastole. And then we have certain observations which are abnormal observations, like this one, 3 cases observed in 2021, where there was no S wave in V5, V6, and these 3 cases were like fascicular VTs, where we have small R dash in the V1, no S wave in V6, and a normal looking axis or an inferior axis in these VTs. 2 of these cases were associated with a typical left posterior fascicular VT, and these tachycardias also got eliminated with the ablation of the posterior fascicular VT. So interesting thing, proposal from this paper was that this may be a form of a reverse type of left posterior fascicular VT. In the typical posterior fascicular VT, the abnormal P1 potential, P1 pathway is activated antegradely and the posterior fascicle is activated retrogradely. While in this type of circuit, the abnormal pathway may be activated retrogradely while the posterior fascicle is activated antegradely, thus leading to a basal exit towards the bifurcation of the left bundle. And this basal exit leads to a positive QRS in V5, V6 and a broader QRS because it's a myocardial exit, and an inferior axis because it's a more basal exit. So then came some observations in 2021 that the septal fascicle may be involved because of its intricacies as discussed by Dr. Samir in the first talk. So an impulse which is arising from the septal fascicle may exit from the posterior fascicle, may exit from the anterior fascicle, may exit from both of them simultaneously. So even a one focus origin of an arrhythmia may give to different morphology of arrhythmias in a single patient, and ablating this single focus will eliminate all these arrhythmias together, different morphology arrhythmias. So this was an important observation, and it thought then the role of mid-septal fascicle was implicated in these patients. And this was a report of 5 patients where they also studied that in a single patient, there was recurrent fascicular VTs with different morphologies. There was a narrow QRS tachycardia, which was probably an upper septal VT, and there was a wide QRS tachycardia, which was typically a posterior fascicular VT. However, all these tachycardias were eliminated by a single ablation in the left septal fascicle area. So this left septal fascicle area, which is a complex network of Purkinje fibers in between the anterior fascicle and the posterior fascicle, solves a lot of mystery, that it is more involved with the posterior fascicle as shown by Samir, and it gives a longer path of conduction, and slowing is also observed in this area because of more of calcium channel dependent conduction and less of sodium channel dependent conduction in this area, which may also prove the sensitivity of verapamil to the of these tachycardias. So the latest concept in the circuit of fascicular VT is given by the Nogami et al., and it was published last year in 2023. It suggests that all the circuit is actually in the septal fascicle, in the ramifications of the septal fascicle, and the posterior fascicle and the anterior fascicle are actually bystanders in the circuit, and the morphology of the tachycardia depends on the exit of the circuit. If the exit of the impulse towards the ventricular myocardium is near the posterior septum, it gives a posterior fascicular tachycardia. If it is near the anterior septum, it gives an anterior fascicular tachycardia, while the upper septal VT remains where both the fascicles are activated simultaneously. So this is about the circuit of the fascicular VT. Coming to more of the clinical features and ECG recognition, which is more important for the audience today. So classically, it is the right bundle branch block, a narrowish looking QRS between 110 to 140 millisecond, and left superior axis, which we need to remember in a structurally normal heart. We should always, it should always ring bells in our mind towards a fascicular VT. Axis is rightward toward in the left anterior fascicular VT. And the main diagnostic confusion is that whether it is a VT or it is an SVT with aberrancy. Important thing to note is often patients come to our emergency with an ECG recorded outside with the VT, but when they reach our emergency, they have already in sinus rhythm. And what may be noted in the sinus rhythm after the wide complex tachycardia is a memory T wave inversion, which is more prominent in the infralateral leads. These kind of T wave inversions are not ischemic. Since there is a history of a wide complex tachycardia and VT, it is often a knee-jerk reflex to post these patients for a coronary angiogram, but it is useless because these T wave inversions are memory T waves and an angiogram is not required. This was a beautiful paper by Mikovits et al. In 2017, where they tried to identify the features for differentiating a right bundle branch block with LAHP aberrancy versus a fascicular VT morphology. So what they found that 4 features were important. That a typical V1 morphology of an RBBB was more pointing towards an aberrancy, while an atypical V1 morphology will point towards a fascicular VT. Importantly and counterintuitively, a narrower QRS, less than 140 millisecond, will point towards a fascicular VT, while a wider QRS will point towards an aberrancy. This is counterintuitive because our general understanding is that wider the QRS, the higher the likelihood of the VT and smaller the likelihood of SVT. But in this case scenario, the narrower QRS is more suggestive of fascicular VT as compared to the aberrancy. The most important criteria, according to me, is the V6-RS ratio. In SVT aberrancy, there may be a deep S wave in V6, but it is always smaller than the R wave. And an RS ratio, which is smaller than 1, is pointing towards an fascicular VT. A very deep S wave, where the ratio is less than 0.15, is always fascicular VT. And lastly, the AVR lead. If the AVR is completely positive, it's point towards the fascicular VT and a more superior axis. And if the lead AVR has a significant negative component, it points towards an aberrancy. So these 4 points are very important to differentiate between SVT aberrancy versus a fascicular VT. And then if we know these 4 points, we can apply this algorithm. When we have this RBB LAHP pattern QRS, wide QRS tachycardia, we have to look for P waves. If there is a VA dissociation and V is more than A, it is clearly a posterior fascicular VT. If the P waves are more than QRS or the P wave is not compatible with retrograde P, it is an SVT with aberrancy. If there is a 1:1 ratio at no discernible P waves, we have to look for QRS axis and V6-RS ratio. If the QRS axis is very leftward and very superior, less than -100, it means that it is more likely to be fascicular VT. If the V6 RS ratio is less than 0.15, it is likely to be fascicular VT. And if none of these is there, then we have to use these 4 criteria. If 3 or more than 3 are positive, it suggests that fascicular VT. If only 1 or 2 are there, then it suggests that it may be an SVT with aberrancy. Another diagnostic confusion is with the
Raghav,
papillary.
you want to keep it short?
Sir, I'll just finish off in another 5 minutes, sir. Not more than that.
It's good.
So another diagnostic confusion is with the papillary muscle, VT, which is wider and more atypical RBBB presentation. There may be subtle ECG variations with no Q waves in 1 AVL in papillary muscle VT. However, the clinical features are more important, with the papillary muscle VT having automatic VT features rather than reentrant features. So coming to the management, so acute management entails the use of IV calcium channel blockers in the form of IV verapamil, and IV diltiazem is also similarly effective. Adenosine and carotid sinus massage are not effective in this tachycardia and not recommended. Beta blockers, lidocaine and procainamide are also show inconsistent responses and not in generally recommended. These tachycardias are mostly hemodynamically stable. They don't require DC cardioversion, and it may be rarely required in cases of unstable patients. Echo showing a structurally normal heart may suffice as an evaluation, and coronary angiogram is not needed. Catheter ablation with a high success rate of around 90% and low recurrence rate of around 5 to 10% is the treatment of choice in these cases for long-term management. If the patient is unwilling for catheter ablation or is too small for catheter ablation, the patient can be kept on an SOS calcium channel blocker, a diltiazem or a verapamil, especially if there is a first episode or if there are infrequent episodes. Chronic daily dosing is less effective and is not recommended in general. While we map, we get these P1 and P2 potentials, and the target is to ablate near the distal end of the exit, where we may find the earliest P2 potential or the latest P1 potential, or when they are fusing. And this is a typical fluoroscopic picture of ablation, where we are ablating near the septum, near the posterior inferior septum. And in case where the potentials are not found or the tachycardia is not inducible, we can map near the exit site and create an empirical line of block by creating a horizontal ablation line in the 10 millimeter proximal to the exit site of the tachycardia. What we often see post-ablation is a left posterior hemiblock with a right axis deviation and deep Q waves and T wave inversions in lead 3 as compared to the pre-ablation sinus ECG. Last slide, long-term outcomes. So this was reported in 2015 in 118 odd patients with a 5-year follow-up, that there was a high acute procedural success with 100% success of non-inducibility of tachycardia. However, VT recurred in around 17 patients, which was approximately 15% recurrence of the same posterior fascicular VT. And there was a new onset of upper septal VT, which suggests that there may be mechanisms which involve other fibers also with different forms of VT presenting in terms of fascicular reentrant. The third type of recurrence which may happen in these patients is due to progression of an underlying diseases like sarcoid or inflammatory cardiomyopathy, which was not recognized on the first episode. I had a case, probably we can skip this case in the interest of time. So my take-home message is that idiopathic fascicular VT is a reentrant VT from the left fascicles. It involves an abnormal slow Purkinje fiber or a mid-septal fascicle sensitive to verapamil. It has a benign course and it occurs in structurally normal heart from 10 to 40 years of age. And the ECG differentiation from SVT with aberrancy is important, and it entails the use of VA dissociation, QRS excess of less than -100 degrees, deep S in V6, narrower QRS duration, and atypical RBBB in V1 as the important features. And these tachycardias are amenable to catheter ablation with good outcomes. Thank you.
Great, Raghav. That's been quite a roundup of the fascicular VTs. We would like to discuss a few things.
Yeah, Dr. Raghav, that was both comprehensive and succinct, as I told yesterday. You almost left no scope for adding comments, but nevertheless, I'll try and kind of reinforce and lay stress on 3 key slides that today's audience should take home, of course, apart from your take-home message. One I thought was they should know to distinguish. I mean, this is apart from Zipes, Triad, and Belazan's additional point. They should know to recognize the pattern recognition of fascicular tachycardia. And of course, now they should be today take home this Mikowicz criteria to distinguish SVT with aberrancy and fascicular VT. That's one key slide that of all your slides. The second one was distinguishing papillary muscle VT and fascicular VT. If I may add one more close differential, that's focal mitral annular VT. Again, that's a close differential. Of course, the behavior would be different. It will be more focal, unlike a reentrant, it could behave like a focal mitral monomorphic VT. So that will be another close differential that today's audience should take home. The other thing that you added one slide on verapamil insensitive VT is like, probably we'll have a little discussion on this on the last talk today, but that's, if I can call it, propranolol sensitive, or it's exercise-induced VT, which will again have a similar ECG pattern to, may sometimes have similar ECG pattern to fascicular VT, and these also should be recognized when fascicular VT behaves differently, unlike the usual typical fascicular VT. I thought these are the two things that should re-emphasize and reinforce for today's audience. So that would be my comments, Dr. Nabar. If there's anything more.
Yeah, sure. I mean, just that the fascicular VTs are right bundle, left posterior fascicular VTs are right bundle branch with left axis as well as with northwest axis, essentially a superior axis, and one can focus more if it's a left axis to the mid-septal region, if it is with the northwest axis more to the apical region while one is attempting ablation. And second thing was about the septal VTs tend to be narrow like that, and to differentiate between VT in relation to infarct, a QR pattern in V1 would be more important. If you have QR pattern in V1, V2, that would probably tell you to distinguish that this is probably a VT coming from a septal infarct, and because it is septal, it's narrow like these fascicular VTs. So those are some of the ECG tips. Does the QRS width help to differentiate, Raghav, between what can be a fascicular VT, idiopathic VT versus what can be a VT in a setting of a structural heart disease looking similarly in overall QRS morphology?
So, sir, more than width, because even the fascicular VTs itself may be associated with coronary artery disease in structurally abnormal heart. So what would be more important would be the clinical features in terms of a young patient presenting with a structurally normal heart. I will think of an idiopathic fascicular VT if the VT is behaving in a reentrant fashion. While in a patient who's 55-year-old and presenting with the first episode of VT, I would think in terms of a scar in the septum causing this VT, rather than looking at the ECG QRS width.
Sure, I think that's well taken. So I think we have, since we are on this discussion, the obvious next step in this would be to discuss the conduction system VT in the setting probably of a structural heart disease, and that's where I think Shomu's presentation will come in. It's about one of the little difficult to understand, but we have a great presenter in form of Shomu. So Shomu, bundle branch reentrant VT and a still complicated interfascicular VT. Tell us, simplify it for us.
Yeah, thanks, Dr. Ashish. Am I audible and is the screen seen?
Yeah, all good. Okay, go.
Yeah. Good morning, everybody, and thanks for having me here. As we see that Dr. Ashish said that this is very rare to see, but it's very important to recognize. It's rare because people don't recognize, and that's the key for this talk, to recognize such ventricular arrhythmias because they can be treated. So this is a patient who presented with an incessant tachycardia, dilated cardiomyopathy, ejection fraction is low, and there is low blood pressure and pulmonary congestion. And if you see here, it's a RBBP left axis deviation tachycardia, and you would see AV dissociation. So you would think that this is a ventricular tachycardia, nothing great about it. But if you see the second slide, wherein you see the tachycardia which is ongoing, and you see the sinus rhythm. The sinus rhythm is same as the tachycardia. So if I was given this two together, I would say, no, this is SVT with aberrancy. Why can this be a VT? So that is the importance to recognize that certain ventricular tachycardias can be the same as sinus rhythm QRS. And what are the differentials? The most important differential would be a His-Purkinje reentrant ventricular tachycardia, which includes bundle branch reentrant VT, interfascicular VT, and a focal His-Purkinje VT. Scar VT arising from near the conduction system can also have, but they may have a little bit different QRS morphology. Rarely, an SVT with aberrancy can have AV dissociation, and this can happen only with AVNRT or a junctional tachycardia with VA block or a nodoventricular nodofascicular tachycardia. AVRT cannot have a AV dissociation. So importantly, to understand bundle branch reentrant tachycardia, what are the components of the circuit? The bundle branches, the fascicles, and transeptal conduction. This bundle is generally a bystander because it is high up after the branch point. So most important would be the slow conduction as evident on the ECG by a PR prolongation or in an EP study by a HV being long. On the ECG, you have bundle branch block baseline or an intraventricular conduction defect. Rarely you have a normal ECG in which functional delay can be a cause of a slow conduction and induce a bundle branch reentrant VT. The second part would be a differential block. A patient who has an antegrade block, that is a right bundle or a left bundle is antegradely blocked, but retrograde conduction is preserved. Rarely would be a functional delay in a conduction. So there are three types that have been described of a bundle branch reentrant tachycardia. The first type, the type A, is the most common, wherein there is a baseline ECG of a left bundle branch block, and the tachycardia itself is a left bundle branch block tachycardia, wherein the circuit antegradally is formed by antegrade conduction by the right bundle, transmural, and then going back via the right bundle to complete the circuit. The important point would be that the HV during tachycardia is generally always more than the HV during sinus. And because the activation sequence is left bundle earlier, then right bundle. The second common type would be a right bundle branch block tachycardia, wherein the baseline there is right bundle branch block pattern in a sinus rhythm, and the tachycardia, the antegrade circuit goes by the left bundle, transeptal conduction, and retrograde by the right bundle. The HV during tachycardia is always more or equal than the sinus. Rarely it can be lesser if his conduction is more delayed. And the activation sequence is right bundle followed by left bundle. The type B is the interfascicular tachycardia, wherein it's from the left fascicles only. The right bundle is a bystander. It is either the left posterior or the anterior fascicle. And herein, the characteristic would be a left RBBB tachycardia with either right or left axis deviation. And the HV during tachycardia is less than that the HV during sinus. However, it remains positive. And the activation sequence would be left bundle, his, and then the right bundle. And the interfascicular can have two varieties, wherein it will be a right axis deviation if it is antegrade through the left anterior fascicle, or a left axis deviation if it is from the left posterior fascicle antegrade conduction. So differential point between the two, interfascicular VT, the HV will be shorter than sinus, but always positive. Bundle branch, HV is longer or equal to sinus, rare to shorten. Interfascicular is right bundle branch morphology, well, most of the bundle branch reentrant tachycardias are left bundle branch morphology. Right bundle is not part of a circuit in interfascicular, while right bundle is an essential part of the circuit, and you ablate interfascicular VT on the left anterior or posterior fascicle. Most of the ablation is done on a right bundle in a bundle branch reentry. As discussed by Dr. Raghav, both can coexist, other can appear after the initial ablation, and you should be wary of the fact. So HV interval holds the key during tachycardia and during sinus rhythm. A word of V3 beat that has been described in around 2/3 of patients with a normal stimulation. This is a bundle branch reentry beat that has been described. Normally, a single beat is seen, and that is because of very fast conduction and relative long refractory period. If you stimulate these patients through a ventricular stimulation, a single reentrant beat with the HV interval being positive would come. However, persistent bundle branch reentry requires disease of the conduction system. And how does the disease occur? It is because of various conditions like this. So either there is ventricular dysfunction or there is conduction system disease. And most of the time you find non-ischemic dilated cardiomyopathy, and in studies, up to 40% of ventricular tachycardia may be because of the conduction system arrhythmia. In ischemic dilated cardiomyopathy, most are scar-related. However, around 6% of ventricular tachycardia of ischemic cardiomyopathies would be related to the bundle branch reentry tachycardia. Of importance nowadays would be TAVI or post-valvular surgery. That is within 2 weeks. The patient who undergoes a MVR or a AVR, there happens a ventricular arrhythmia, and these may be related to the compression of the bundle branch that happened, especially if the left bundle is compressed. Neuromuscular diseases, especially myotonic dystrophy, may only present with a broad complex tachycardia in the presence of a normal ejection fraction. Drugs like flecainide can induce in a diseased heart. HCM recently has been described by Muthaiya et al. ARVC, Epstein's anomaly sometimes present with bundle branch reentry, Chagas in especially the South American countries, and it is very rare to have these bundle branch reentry tachycardias with a structurally normal heart. So clinically features, most of these are related to the underlying disease. If they have a tachycardia pre-syncope, syncope, or a cardiac arrest, because very fast rates are seen with bundle branch reentry tachycardias, baseline ECG demonstrates bundle branch blocks or IVCD. It's very rare to have a normal QRSS baseline, and PR prolongation is not very uncommon. VT ECG is rarely seen. However, if it is seen, a VA dissociation is generally seen, and the tachycardia is similar to that of a sinus rhythm. There is a rapid intrinsicoid deflection, especially in the left bundle branch morphology. The axis may vary from left axis, right axis to a normal axis. Many a times these VTs are induced by coexisting atrial flutter and fibrillation because they cause the RR variation. And as discussed, the atrial pacing sometimes can induce, and these are responsible for that irregular beats causing a differential refractoriness and inducing the arrhythmia. So if you see this ECG, the first half shows a bundle, the tachycardia, which is of a similar morphology of a sinus rhythm. And you see, notice that it is more broader as compared to the sinus rhythm. However, it is nearly the same morphology, and it is very fast. So remember, they are very fast and hemodynamically unstable. So how do you evaluate them? Definitely you evaluate for the primary cause, LV dysfunction, do a CAG. Neuromuscular diseases to be ruled out if you find that there is no LV dysfunction. A Holter to see for other morphology of PVCs or atrial arrhythmias. Very importantly, to understand that if you do a patient a cardiac MRI and you have a patient with LV dysfunction who presents with arrhythmia and you find no scar, such patients should be subjected to a EP study to rule out bundle branch reentrant VT, as it is easily treatable. Treatment-wise, beta blockers and amiodarone is what we give generally for LV dysfunction, but generally they are not effective and the patient has frequent recurrences. You should avoid other drugs. EP study in RF ablation by ablating the right bundle, left bundle, less commonly, and in interfascicular VT, left fascicle gives a permanent cure. But most of these patients would receive a AICD or CRTD, as VTs are associated in 60% of the times from various other sites. And post-ablation, or because of LV dysfunction, most of them would have a worsening conduction and a AV block requiring pacing. So most of them would end up with a device. What about the outcomes? The prognosis depends on the underlying disease. The LV dysfunction and heart failure since CRTD is then given. Recurrence after unsuccessful ablation would be extremely unlikely, and patients who have a preserved LV function and no other risk markers, the strategy is actually not very clear because there is very limited data. Most of them would suggest that there is a very good outcome and you may end up not giving an ICD, but whether a repeat EP study is required or not, we should see. So lastly, I'll just present in 1 minute of this case, a baseline left bundle branch block presenting with recurrent palpitations and giddiness, and there was no scar on MRI. So we did an EP study for this patient, which we found a HV which was prolonged for 70 milliseconds, and a tachycardia which was induced easily by ventricular pacing from a ventricular extra. And this tachycardia showed that the H preceded the right bundle potential. So any tachycardia which is reproducibly induced by a ventricular pacing with a stable His or bundle branch potential preceding the ventricular activation and gives a sequence of a His, right bundle or left bundle activation sequence, and the changes in HH which precedes the change in the VV suggest a bundle branch reentry. And if you block his Purkinje system by mechanical block or by an ablation, it will not be induced. So you ablate the right bundle. As you can see here, the mapping catheter is ablation near the right bundle. And what you see is initial automaticity, and then you have a right bundle branch block. But notice that from a PR, which was normal, you have a PR prolongation, and it goes. So there is actually, once you block the right bundle, you can say that this left bundle was not actually a conduction block. It was delay in the left bundle that was responsible for the left bundle apparent block in sinus rhythm. And post ablation, you can see that the PR has prolonged both in the right bundle and the left bundle with a prolonged HV. The patient received a CRTD. In interfascicular, this patient had a right bundle left axis deviation tachycardia. HV was prolonged, and during tachycardia, the HV shortened. However, it was positive, and the ablation was done in the left side. So interfascicular reentrant tachycardia can have an antegrade from a left anterior fascicle or from the left posterior fascicle, and can have both. So summarizing, bundle branch reentrant tachycardia should be considered in patients with dilated cardiomyopathy, especially if there is no scarring present and the tachycardia morphology is similar to that of the QRS morphology in sinus rhythm. It is easily treated by ablation, so hence should be referred for an ablation prior to an AICD implantation. Most of these patients would have a structural heart disease, and if they don't have a structural heart disease, definitely an EP study and a neurological evaluation should be done. However, device therapy is required in most patients. Thank you.
Thanks, Shomu. Very succinct. Hi, Grim.
Yeah. Already, Dr. Nabar has snatched the word from my mouth. So that was a.
Sorry.
No. The truth is always the same. No, it was a elegant presentation of, and concise in such a short time. You made it so simple and very elegant. And I should actually, on behalf of the audience, I should thank you for this. And that is to be expected from Shomu, who has done some excellent work. For the audience who may not know, Shomu has done some excellent work in the past decades in this area. He is one of the real experts in this country in this area. Shomu, I really don't, want to add something to what you already said. It's very difficult to do that. But let me ask you two questions on behalf of the audience, which fellows have asked me repeatedly. And they may not ask now. I want to ask so that it's clarified. Number one question is, as you rightly said, many of these patients, actually all of these patients have structural heart disease, DCMs, and they have, and the last summary you have said that invariably they require devices. Now, in a patient who has DCM, who has a VT, what is the need to diagnose a bundle branch reentry ET? Because anyway, they are going to get an ICD. That is question number one. Both you answer together. Question number two is, conceptually, we have been telling that conduction system VTs are narrow. Now, this is a VT which is going from left bundle, right bundle, both are conduction system. Yet, when compared to the baseline ECG, the QRS is wider during VT than this one. So these two questions, why is it that despite conduction system being involved, you have wider QRS VT? And why IC, despite ICD, why do you need to actually diagnose for a general cardiologist? Thank you.
So coming to the second one, why it is more wider? It is basically a function of rate. So at a slower rate, the conduction system would conduct at a specific rate. The QRS would be wider, maybe 140. But if you increase, the delay in conduction would be more as compared to a slower rate. So from a QRS of 140, it may go up to 160, even 200. And as the decremental property of the conduction system, especially if it is diseased, is the reason that it becomes more and more wider. So that answers your first question. Second question. The first question is, how and when do you recognize and why it's important? The most important thing is it doesn't respond well to either beta blockers and amiodarone. And you have a recurrent VT, which is not responding, and you have recurrent ICD shocks. And very importantly, if you see that the far field QRS, the morphology during sinus rhythm and during the VT is similar, that should raise a concern that this is likely to be a bundle branch reentrant VT, and it could be easily treated by a simple ablation in the right bundle. So patients who have DCM, A patient who has DCM, you are giving beta blockers, you are up titrating amiodarone, and still it doesn't respond. You do an EP study, especially if your EGMs match. That's the key. If you have a good electrophysiologist, he will recognize that and take him for ablation and easily treat.
Two nice things from your presentation, Shomu, because the QRS morphology matches with the sinus. Sometimes in not so fast VTs, you might have difficulty in differentiating from a sinus or atrial tachycardia. One of your ECGs clearly showed a VA dissociation. So if you can look at that, then this difficulty does not exist. And again, you showed very well also that yes, normally you should be concerned to arrange a device when you are ablating the right bundle in these patients who have left bundle branch block in the sinus rhythm. But you clearly brought out that point that the left bundle branch block pattern is not always a block in the left bundle, but could be a delay in the left ventricular activation, and therefore not always for the reason of creating a complete heart block would you need a device. That would be an independent indication based on the VT risk or a CRT indication. Both excellent points. Thanks, Shomu. I think it's always in the interest of the time that we have to move further.
Ashish,
Yeah, I agree.
one question,
Yeah.
one question from the audience to
Yeah.
Shomu.
Yeah.
Dr. Dheeraj is asking this question. Would you be afraid to ablate the right bundle in these bundle branch reentry VTs with a diseased left bundle, and it might lead to CHB? And would you keep pacing ready in the same setting?
Yeah, so most of them would be pacing ready and pacing required. That is what I would say. Most of them have a HV disease. However, as I said, if you have an LV dysfunction, if you have a patient with LBBB baseline, anyway, they are with heart failure, you would be giving them a CRT, obviously. And this procedure is done to decrease the arrhythmia burden rather than give a treatment for heart failure. In patients with neuromuscular diseases, especially myotonia, actually these patients do very well if you just ablate the right bundle, and most of them would not end up, only around 30% maximum. In fact, some studies quote only 5% of incidence of AV block or worsening AV conduction, but maximum is 30%. So I would tell the patient, no, you may require a device. However, most of them would not go into AV block, only that the HV may prolong to a certain extent rather than have a AV block.
Right. Great.
Can there be a slow rate bundle branch reentry VT looking like AF with LVVV in a DCM case? Another question.
Actually, as I said, it goes into an interfascicular VT rather than a bundle branch reentry, because if you achieve block in the right bundle properly, it doesn't conduct slowly. It either doesn't conduct or it will conduct at the same rate. What happens is interfascicular reentrant VTs are much slower, as I showed in the case, and it goes into that interfascicular reentry mode wherein you have to go to the left side and ablate one of the left-sided fascicles. And the HV interval is the key. So if you check the HV interval, it will change.
Great. Thank you, Shomu. That was a great presentation.
Sure.
Thank you, sir.
I think time to move on. I mean, some years back, nobody would have agreed that we can ablate for VF, but the envelope of ablation is always being pushed deeper and deeper, and more so by the group from Bordeaux, from Professor Michel Hesseger's lab. Nobody thought AF could be ablated, and that's now very much done. Progressed from ectopy ablation in the pulmonary vein to pulmonary vein isolation. And the first series on ablating for VF was again published from the same lab. And we have Dr. Priyanka Agrawal to tell us how to ablate in the Purkinje system for VT and VF. Priyanka, please come on.
Yeah. Okay.
Dr. Bhim Shankar would moderate this session for us. Yeah, please share your screen.
The shared screen is in the lower part, green button. The lower part, green button. Can you press it?
Yes, I've already shared my screen. Is it visible?
No, it's not.
No.
Yes, now you're sharing, but this is my bundle branch reentry.
Yeah, no, this is good now.
Is
Yeah.
it visible now?
You're audible. Your slides are visible. You can launch.
Okay. So good morning, everyone. Thank you to the Dr. Shumugura sir and the IHRS team for giving me this opportunity. So we'll be discussing Purkinje fiber VT. So basically, Purkinje fiber VT is a huge topic. Most of the things have been covered up in the previous talks. So to keep this talk brief, we'll be mainly focusing on short coupled VF and VF in ischemic cardiomyopathy. So Purkinje fiber VT, any change or damage in the Purkinje system can cause polymorphic VT or VF. These arrhythmias can be idiopathic, can occur in structural normal heart, or they can occur in structural heart disease like ischemic, dilated, or hypertrophic cardiomyopathies, valvular heart disease, or myocarditis. So we'll just begin with a case scenario. So here is a 59-year-old man presenting to us in ED with complaint of chest pain, diagnosed to have anterior wall MI. The patient was taken in the cath lab, PCI to LED done. The patient was doing well for almost 2 days. On the third day, he started having polymorphic VT runs triggered by PVCs every time, and like managing any polymorphic VT in ACS, we look for the ECG was showing normal QT interval. The electrolytes were normal, normal potassium, normal magnesium. There were no sign of ischemia. We started the patient on Zalocard and beta blockers. The polymorphic VT runs didn't responded. We added amiodarone, it didn't responded. Even we took the patient for a check CAG, which showed the patent coronaries, and even we added ranolazine, phaneton. Nothing worked up actually. Still, a ganglion block was given. Nothing worked up. So after DC version, this was the ECG. It showed every time like some frequent PVCs were there with RB morphology, superior axis. So with no option left, we gave patient quinine, and after quinine, this is the ECG showing normal intervals. The PVCs got suppressed, and the polymorphic VT runs were not there now, got suppressed. So coming to this, so post-MI Purkinje VT-VF, it can occur 3 to 8 days after MI or a revascularization, usually triggered by a short-coupled PVC. These are mainly refractory to the conventional antiarrhythmic drugs like amiodarone, lignocaine, beta blockers, and even stellate ganglion block. And these can lead to VT storm. So mechanism of post-MI Purkinje related arrhythmias. There's all post-MI, there's alteration in the cellular electrical activity of Purkinje fibers, which gives rise to delayed after depolarization, triggered activity, and even increased automaticity, which can cause polymorphic VT. And during the healing phase in MI, there is basically a unidirectional block, which again promotes re-entry causing polymorphic VT-VF. Management to this is quinidine has been found useful in the Purkinje fiber related VTs. And if quinidine is not available or using quinidine is an issue, then taking the patient in the EP lab and mapping the PVC, which is triggering VF every time, is a bailout option. So here we can see that just a simple intracardiac EGM, which is showing the mapping catheter is at the ablation site. And here we can see that the PVC... Hello, so am I audible?
Yes, you are audible. You go ahead.
Yes, sir. So here we can see that the PVC is being mapped, which showed that Purkinje potential preceding the PVC by almost 97 millisecond. And here ablation was done, which silenced the PVC and there were no polymorphic VT runs. So here we'll just have a brief discussion about the quinidine. So quinidine was initially, it was used very much, but due to history of polymorphic VT and VF and risk of sudden cardiac death, the use was discontinued. So it's basically a class 1A antiarrhythmic drug. Like other class 1A antiarrhythmic drug, it's a sodium channel blocker, as well as additionally it has a delayed rectified potassium channel blocker action also, and ITO channel blocker action also. The doses which we use in ventricular arrhythmias is usually 1 to 2 gram per day. Monitoring of QTC interval is required and QRS duration is required, as there is a risk of torsades. If QRS complex or QTC intervals widens to 130% of its pre-treatment duration, or the QT or the absolute value of the QTC is longer than 500 millisecond, it is advised to withhold quinidine. So quinidine is availability is an issue, especially in the Southeast Asian countries. So quinine is an alternative to it. So just a brief note about quinine. It's an isomer of quinidine only. It has similar pharmacological activities. It's equally effective in suppressing ventricular arrhythmias. Pro-arrhythmic potential of QT prolongation, torsades, is comparatively less. The main problem with the quinine is auditory side effects at synchronism. And doses of quinine, what we have seen in different case series coming from India and other countries, is usually 900 to 1200 mg per day, which is lesser than its anti-malarial dose. So the other substrate which we'll be discussing is idiopathic VF, which is now commonly known as a short coupled VF. It is one of the rare causes of unexplained sudden cardiac arrest in otherwise healthy individuals. Idiopathic VF is basically a diagnosis of exclusion. So the diagnostic criteria for idiopathic VF is basically a documentation of VF or any polymorphic VT, which is initiated by a PVC with a coupling interval of less than 350 milliseconds, plus exclusion of other causes like Brugada, early repolarization, long QT, CPVT, for which we can do a cardiac MRI, TMT, or a sodium channel provocation test. So molecular and genetic aspects of idiopathic VF, it's still largely elusive. Positive family history of sudden cardiac death is found in 8 to 15% of the patients. DPP6 gene mutation has been described. It's basically, its role is in regulatory beta subunit of ITO channel. So here we are going to discuss one another case scenario. So basically a 29-year-old lady coming to us in the OPD with history of recurrent syncope. Echo is okay, echo is normal, the ECG is normal, QTC interval and everything is normal. We admitted the patient who got a Holter test done. So the Holter study was showing frequent PVCs, RBB morphology, superior axis, and these PVCs are repeatedly triggering the polymorphic VT runs. So basically a strictly normal ECG, normal QT intervals, arrhythmia onset with ultra short coupling intervals. And every time it's the same only during the Holter. So it gives us a suspicion of idiopathic VF. So all patients with short coupled VF with history of resuscitated cardiac arrest or documented polymorphic VT-VF should receive an ICD. Single therapy zone with a high cutoff rate, like more than 210 to more than 220, and a long detection interval is set. Adjunct treatment with quinidine is recommended for patients with idiopathic VF with frequent VF recurrences, patients with electrical storm, or those who refuse to ICD implantation. The optimal quinidine dose for short coupled VF is the same only as we used in post-MI Purkinje fiber VT, 600 to 2 grams per day. Alternatively, in some case series, where since quinidine availability is an issue, verapamil has shown some rules. And for patients with recurrent ICD therapies, VF episodes despite adequate medical treatment, RF ablation of triggered PVC is recommended. Is another option actually. So that's it. Thank you.
Sure, Bhim, please take over.
Yeah. Dr. Purkinje, yeah, that was concise, and you had two good cases exemplifying Purkinje fiber mediated VT. From what I gather, the first case, although when you presented the case with the short couple VPC, you said verapamil is a choice. You didn't use it in the first case that you presented. Was there some reason that you did not try that?
So patient was getting hemodynamically unstable, and this severe LV dysfunction was there. So we were slightly reluctant to use CCBs actually.
Right. Fair enough. So from what I gather and what I think the audience should take home is, one, Purkinje fiber VT can be in structurally normal heart, two kinds. One is short couple VPC. The other is one which Dr. Raghav discussed, the verapamil insensitive VT, that is focal Purkinje VT, which actually is very similar to fascicular VT. And the second one that you had exemplified with the case. So that either verapamil quinidine would be a choice. In structurally normal heart, although you showed a case with the Purkinje fiber VT that's manifesting immediately post-MI, the mechanism would be again triggered activity in this scenario. But there's also another scenario where you can have Purkinje fiber VT that's happening after a remote MI. So that the mechanism, some of us would remember Frank Bogan's case series where reentry is a mechanism here which can happen late after MI. So this is similar to any other scar-related VT, except that the VT will look narrow QRS and typically of VTs that arise from conduction system. So the take home for our audience today should be two kinds, one in structurally normal heart and the other in structurally abnormal heart. So structurally normal would be short couple VPCs and focal Purkinje VT. And in structurally abnormal heart, either early MI or remote MI. And of course, all other kinds of myocarditis and all the structural disorders can again have Purkinje related VT. So if I have summed up that should be good enough for as a take-home message for today's audience.
Priyanka, I particularly liked your slide 5, if you can put it on, and that's important for everybody to look at, because that is what most of us on the monitor would have to be a little attentive to pick up these kinds of repetitive, similar morphology, short coupled PVCs. As you said, 12 lead ECGs don't get recorded so easily, and then if on your rounds, most of these patients would be with interventional cardiologists, and therefore it is important to bring that to the notice that if something like that is noted, then like in your patient, all the options were exhausted, you might bring in the option of ablation earlier when repetitive shocks are required. Highgrave also, I think, has some experience, and we have often discussed this telephonically. Highgrave, you want to pitch in some thoughts?
Yeah. Only thing, there are a couple of things in Priyanka's presentation that I would say. She has mentioned quinidine many times. Unfortunately, quinidine is not question of difficulty, it's practically not available. And in fact, the chat box, a lot of question on quinidine. Either Shomu or Ashish, have you ever been able to procure quinidine? I was not able to, despite extensive efforts in this direction. That is,
Quinidine was going to be available by a company, but however, before there are some studies which show that quinine use is not bad as compared to quinidine. The difference between quinidine and quinine has to be known. So what studies have said is quinidine has both a slower conduction, so it slows the conduction, as well as it increases the refractoriness. While quinine just slows the conduction, it doesn't increase the refractoriness. And that is one reason that it may be lesser effective as compared to quinidine. And that is why quinidine per se is used for arrhythmias and quinine is used for anti-malarial, because even though they are of the same alkaloid group, their actions on muscarinic receptors and potassium are different. So quinine doesn't affect the potassium channel as well as the muscarinic receptors. And that has been seen in studies that it only affects more of a sodium channel blockade, and it's morely, therefore sometimes quinine is not as effective as quinidine. However, when you give quinine, you don't find a QRS width or a QT prolongation which is as equivalent to quinidine. So therefore, monitoring the QRS width and the QT prolongation with quinine is limited for its side effect. So you can use quinine per se, and which is available as an anti-malarial, but however, you have to give the least effective dose rather than start at a higher dose. And that's very important take-home message, I think.
Second point is ectopy. For common general cardiologists, it's very important because a lot of patients are referred and a lot of concerns are expressed. Many times on telephonically, they asked patients has ectopy, what is to be done. So it's important to realize what are the ectopy which need to be seriously considered. One of them is multiple, some of them are well known, otherwise, multiple morphologies of VPCs. One of the things that is relevant to this discussion is a short coupled. Now, there is a lot of literature on what is short coupled. Priyanka, in your case, what was your literature say? What is short coupled VPCs? How much is the milliseconds wise?
So less than 350 milliseconds. That is what mentioned in the literatures.
In the literature. Now, there is also literature, new chapters, new data has come in or in a very good article, not show short coupled VPCs causing VF. So people do consider that it is 350 is documented, 350 to 400 is a gray zone, but not show short. It does paper says. So it's important to understand and recognize when you see a lot of VPCs, you say it's only a VPC, there's no problem. So very rarely we measure the coupling interval when we are estimating. So this is a new point that needs to be ingrained in our clinical judgment, that when we see VPCs, we have to see how short they are and then prognosticate accordingly.
Just to remind, this is all in absence of long QT, right?
Absolutely. Absolutely. We are talking about a absolutely normal ECGs coming with ectopies.
Sure. So I think we are nearly end of our session. What I'm going to do is ask each one of you, all the speakers followed by the two moderators, to quickly say in maybe 1 or 2 lines as to if we have left out something and what they would want this audience to remember. So let's start the way the presentations were made. Samir, you want to highlight something?
No, sir, not much.
Sure. Raghav, any take-home message which we didn't discuss maybe?
No, sir, probably we have covered a lot of ground, and probably we have discussed everything in detail except the intracardiac EGMs, which were not beyond the scope of this discussion.
Yeah, it's true. It's true.
So from my talk, the take-home is that most important take-home is the SVT with aberrancy versus the VT differentiation. And to understand that although the circuit of fascicular VT has been simply put with an abnormal diastolic pathway, but it may be more complex, and we may have more understanding in future, and current understanding is all hypothetical.
So since you make that point of differentiation, usually a right bundle branch block with a left axis or a northwest axis is already disparate to the bundle branch block, and that's nearly a hard criteria to say this is going to be a VT, except in a situation where in sinus rhythm you have a similar pattern. If you have in sinus rhythm a right bundle branch block left axis and you get a tachycardia taking over that morphology, then is the only scene where you might call it a SVT, and for that you need a old ECG, which is a general dictum that you should try to pull out an old ECG if possible when a patient comes to the emergency or something like that. Shomu.
Yeah, so I would just add that papillary muscle moderator band VTs, these also constitute part of possibly the conduction system, which are rare, and I think to recognize them would require specialization and high degree of suspicion. The last thing would be these RVOT VTs are occasionally said to be because of the his Purkinje system also going into the RV outflow tract. And the use of diltiazem or verapamil calcium channel blockers, especially post-MI, has to be very well understood rather than just give them in a patient with LV dysfunction and cause more heart failure. It may be prudent to give them only if you have a high degree of suspicion for Purkinje fiber. And maybe that's the area where the EP electrophysiologist reference should be done, especially for a cardiology setup post-MI incessant tachycardia.
Sure. Beam?
Yeah, one with regards to Dr. Agar's talk, I would think apart from pattern recognizing fasciculity, people should always bring in the close differential diagnosis. One is papillary muscle and focal mitral annular VT. And with regards to Dr. Priyanka's talk, I would think typically most of the short coupled VPC, the so-called short coupled idiopathic VF, are right bundle morphology. But if you look at Dr. Hasegary's paper, half of them are actually RV Purkinje fiber, which will be in the RV free ward. So we should also look into that kind of VPCs that can, typically 2 patterns of VPCs that can trigger off VF, idiopathic VF. So these are one point that I thought I can add on to.
I agree. Who better than you to sum up a VT session?
Yeah, actually, for the DNBs, I would like to say the following things. The first thing is that this is a rare subset of VTs that we have discussed today. The first question we'll ask is that, because that comes to your mind, is such a rare things. Why are we being taught, and why should we be so interested as a general cardiologist?
Except the fascicular VT, right? I agree.
No, even that rarer than the VTs that general cardiologist sees. So I would like to say, so the reason and recognition is important. First thing is, please remember, as one of the speakers has said, that VTs are generally wide QRS. So whenever you have a narrow QRS, you generally don't think of VTs. You think of SVT only. So when you have a patient with a narrow QRS, what looks like SVT? You have a AVR positive, and we have deep S waves in V5, V6, and you have a VA dissociation. Please carefully look about this. Despite being a structural heart disease, please think about a RBBB morphology. So RBBB morphology, AVR positive, structurally normal heart, V5, V6 deep, VA dissociation. If these things are please there in a narrow QRS complex, please think about these VTs, because these VTs need to be treated separately. Many of the practice is to continue giving them some drugs, 1, 2, 3, and they go on forever, because these are eminently ablatable, curable completely if properly referred and proper hands. The second thing is, among these, as Ashish did say, you should know, in terms of, if you concentrate on the speakers, you must also recognize the prevalence also. The rarer you make a diagnosis, the rarer you are right. In medicine is right here also. So don't try to make a diagnosis of septal VTs, interfascicular VTs, when you see a narrow QRS tachycardia and trying to make a VA dissociation. Try to make a diagnosis of posterior fascicular VT, most common. Anterior fascicular, less common, you did not make. So please remember that all these VTs are narrow QRS, right bundle branch. You may not make a specific diagnosis of the VTs discussed today, but as a Purkinje fiber VTs, if you can think of these things, these are extremely important, because their treatment is different, and don't put these patients on amiodarone for a long term with amiodarone toxicity and all these things. Please do consider these. The second thing is Shomu's talk. When you have a dilated cardiomyopathy, LV dysfunction, and it's very easy, it's not very difficult from what he has made it so simple. If you have an ECG, baseline ECG left bundle branch block, a VT also having a left bundle branch block, exactly bang same, 12 by 12 same, please think of a bundle branch reentry VT, and these are curable. Now I'm re-emphasizing all these things because when I went through this journey from a DM student, all these things were so esoteric, they're coming from Mars, that I thought in my life I should never even look at them as if I was general cardiologist. So, but these are important if you remember these basic things in mind. Thank you.
Thanks, I agree. I think Shomu really made a brilliant construct of this program, and you would be happy to know that we had almost 150 people attending the program, and they remained so almost to the near end, starting from 50. So I think it was an escalation, and we had a really good program as usual, but this was a especially good program. So thanks, Shomu, to you and the UN Mehta team for doing this, and obviously to Dr. Haigreve and Dr. Bhim Shankar for sparing their time on this program today. Thanks very much. Until next time, we will have the group from Coimbatore presenting. I'll know from them what exactly. But this remains interesting, and I hope more and more postgraduates join. Those who are on the program, please encourage in your departments that this is a program that will help you in your syllabus and in your exit exams also. Okay, bye-bye. Thanks, everybody. Bye.
It's Ashish Ki for doing this program regularly.
Yeah, it's a pleasure. Thanks. Bye, Shom. See you guys.
Thank you so much.
Bye, Bhim. Bye, Haigreve. Yeah.
Thank you, sir. Bye-bye.